Yeah, thank you. Right. Whilst the all the talks preceding mine have made my job very easy, and I do thank AIOS and Santon to help me present my experience with Tafluprost in India. I do have a few disclosures, including Santon. So whenever we talk about a prostaglandin analog, one of the very pertinent questions is, do we really need another one? Now, this one has a back concentration, or the preservative concentration, which is much lower than of other commercially available back preserved anti-glaucoma medications. Plus, on top of that, you have a non-preserved one as well. So let's see whether that has made any difference. As with any PG analog, the efficacy of the drug depends on the outflow mechanism, and this, like all other PG analogs, is through the non-conventional channel. Now, desirable characteristics of any anti-glaucoma medication is, of course, its efficacy as well as its safety and tolerability, as alluded by several speakers before. Not only to reduce IOP in the short term compared to the current gold standards, or but also long-term IOP, 24-hour IOP, and preservation of visual fields. Also desirable is that it is effective in all etiologies of glaucoma, and effective when administered not only in treatment naive eyes, but also when you are switching it and as an add-on therapy. And they should be gentle to the ocular surface without any serious side effects, and definitely no systemic side effects. So when we balance both efficacy and safety and tolerability, that's when we can ensure both persistence and adherence with therapy. So just a brief idea about Tafluprost. It received FDA approval in 2012. There were other players in the market then. It was based on several controlled clinical trials. I will mention two. One is a 24-month phase 3 clinical trial of 500 and more patients, which established, comparing it with latanoprost, it established non-inferiority of Tafluprost when you compare it with latanoprost, and also rate of hyperemia and other ocular surface symptoms was much less compared to latanoprost. Another study, which was randomized double-masked 12-week Tafluprost versus Timolol, this too showed that greater than equal to 25% reduction was achieved by 60% at 12 weeks. And again, rates of conjunctival hyperemia only about less than 5%. So a very acceptable safety profile. Now, Tafluprost, there are several studies which have shown that Tafluprost provides effective 24-hour control. In this particular study, you can see, compared to baseline here in the blue graph, the Tafluprost has done well throughout the diurnal period, including nictohemeral. At all time points, significantly reduced. This was alluded to before by Dr. Murli Ariga. Even long-term control in several etiologies of glaucoma, it has been found to be significantly reducing IOP at all time points. And what is more important is that survival in terms of persistence and adherence was almost 85% at 1 year and 76% at 2 years, which is pretty good. And adverse reactions were 18.64%, but most of them were not, they were self-limiting, should I say. And this was a study that was conducted after marketing, post-marketing survey. When compared to other prostaglandin analogs, travoprost as well as latanoprost, it was found to be effective. This study was done again in Japan in 90 NTG patients, and you can see the effect. And when it was administered not only in treatment naive eyes, but also when they were switched and when it was given as add-on therapies, it significantly reduced intraocular pressure. So what about safety and tolerability? We all know these kind of eyes means there is a dip in persistence and adherence. But When a study was done, when photographs were taken after administration of the 4 different types of prostaglandin analogs, and it was the photographs were binarized, and they were then measured by an automated hyperemia analysis software. It was found that Tafluprost had the least amount of hyperemia. Other than this, I can show you photographs now of real world photographs of my patients. You can see both eyes are red, but left one is more than the right one. This is actually post-surgery, 1 week post-surgery. Patient has done much better, but you can see this is a JOAG patient in early 40s. You can see the changes, orbitopathy, as been alluded by Dr. Harsha. Yet another patient, even younger than the other one. This patient is only 32 years old. Now, his eyes are not red, but look at the amount of tightness of the lower lids, the cicatricial changes that are associated with this orbitopathy. And what takes the cake is this. It really breaks my heart seeing this 23-year-old, very smart young management student who first came to me with PDS. She had very advanced glaucoma in the left eye. That surgery was done almost immediately, I would say within 3 months, yet look at the changes in her orbit. Unfortunately, the right eye continues, or at the time this photograph was taken, she was still on anti-glaucoma medications. Since then, of course, she's had trabeculectomy. And when a study of DUES was done, but this has also been alluded to, I will not stick to it, and our very own example in an Indian eye. So I will present to you my experience of Tafluprost in a limited number of patients. Please remember that this was introduced in India only in August last year, launched, both Rajul and I were there, fortunate enough to be there. And because of the COVID situation and the lockdown period, a lot of follow-up has been very erratic. So I don't like to present anything which is less than 6 months. So I currently only have 26 eyes, more than six or more than 6 months follow-up, of which 10 are treatment naive. Follow-up is almost 9 months, and switch or 16 eyes follow-up is close to that. Etiology, a majority were primary open-angle glaucoma or its variants like NTG, OHD, and JOAG, and there were a few primary angle closure glaucoma eyes as well. So in the treatment naive group, the pre-IOP maximum was 23, and the post-IOP was 15.8. So I achieved a decrease of 34% at about 3 months, and this was sustained at last follow-up to about 31%. This decrease was statistically significant. And there was not a single patient who did not report comfort with the eye drops. When it was switched, and again, follow-up being more than equal to or more than 6 months, they were 16 eyes, 8 were on other prostaglandin analogs, some were on fixed combinations, and the reasons for switch were inadequate IOP control or red irritable eyes, or a combination of both, and in some I wanted to change to a single agent, making the treatment regime simpler for the patient in accordance with quality of life. So here we are, these 16 eyes, pre-saflutan IOP, meaning patient could have been on other drugs, other prostaglandin analogs, was 19.1, and post-saflutan IOP, when all other drugs were stopped, was 15.4. So this was obviously significant, but what is more important is that additionally another 20% reduction was found. We have to see this in context. It's a very small sample size, but I'd like to take you through a couple of cases as well, which tells me about the representative cases that I have actually managed in the real world. This is a 50-year-old male. He underwent clear lens extraction elsewhere 2 years ago for very high myopia, and he was 20/20 in each eye, yet he complained of deteriorating vision. His intraocular pressure, as noted elsewhere, was 18 and 17 on a prostaglandin analog on which he had hyperemia and irritation. His CCT was average and his gonioscopy was open. And as you can see, a very, very cupped, shallow cupping, which I think probably got missed. As you can see, in February 2019, visual fields, especially in the left eye, were a lot better with VI5 of 78%, not so much in the right eye. but central visual fields really, really advanced damage. However, the patient only came to me in October 2019, where I was very, very surprised at the change in the visual fields in both eyes, especially the left eye. So here we are, much more advanced. What I did for the patient, because the Tmax as documented, I'm not sure whether this is normal, where it was documented with NCT or not, but it wasn't mentioned, but it was 19 and 21 and the patient was 1870. So I definitely wanted a pressure much lower than that, because the reduction I have got is not significant here, or the reduction that was achieved was not significant. So what I did was I switched to Saflotan, and I got a pressure over the next year whenever I could get a follow-up of 14 to 15. Not much fluctuation, which is what we want. And what is most important is that in this 1 year, he has not deteriorated any further and continues to remain the same as when he presented in October 2019. So he was stable at 1 year. Another case, this time now a 75-year-old pseudophakic general surgeon whose son actually is an ophthalmologist. He told me that he had sulfur allergy amongst others, and he had red eyes whilst reading. So initially he was diagnosed as conjunctivitis, and he was given antibiotics and lubricants, not by me, by his son. And he complained of increased redness and watering and difficulty in reading. Subsequently, he was diagnosed as glaucoma with Tmax of 22 and 32, and the CCT was average. He was given Simbrinza before he came to me, and these are his visual fields. As you can see, the left eye much worse than the right, with fixation, with changes very close to fixation, or just about involving fixation. So on presentation to me, his vision was 20/30 and 20/40, and his pressures were 19 and 21 on Simbrinza, on fixed drug combination of CAI and alpha adrenergic. I don't have photographs then. He was so uncomfortable, I could not document it, but this is my clinical notes. And as you can see, he had an inferior notch in the right eye, and he had a bipolar change in the left eye, and very small discs, that too. I wasn't sure whether this is primary open angle glaucoma or pseudophakic. That didn't matter. But what mattered is, why was he getting so much redness and irritation with the drugs that he was on? And I questioned back allergy. So I discontinued everything and I put him on Saflotan S. For those who are not familiar with the Unim's preparation, I'd just like to show you. It comes in a package like this. It has to be refrigerated, of course, and it comes in packs of 10. 3 packs. So you have for a full month, and then you have to detach each Unims, open it up, and apply the drops in each eye. This is not the same patient, don't worry. And of course, discard after. Once it is opened, it has to be discarded after that. So here, have a look at this patient. He first came. The next time that he came was 1 week later, and his pressures were 12 and 15. Remember, it was 19 and 21 before that. So obviously, my diagnosis was back allergy, because on Saflotan S alone, he was improved almost 70% within a week. Followed by, this is his picture at the same time. And then when he was seen about a month later, just before the lockdown, actually, you can see that his eyes are much less red. He, of course, have floppy eyelids and so on and so forth, but he was much better. And at his last follow-up, his intraocular pressure was 11 and 15. I could sort out his problems of increased redness and watering, but unfortunately, difficulty in reading was because of his visual field defect, and that, as we all know, is permanent and cannot be reversed. So, where Tafluprost is concerned, there is definite IOP lowering efficacy over 24 hours as well, which is similar to other gold standard right now. There is some evidence that there is superior safety and tolerability compared to other prostaglandin analogs, and that the preservative-free Saflotan S is a very important medication in your armamentarium, where ocular surface disease is concerned, as well as where back allergy is concerned. And hopefully, with all these above factors, Patients should remain persistent and adherent with their therapy. And of course, where Indian experience is concerned, we have to keep following up our patients. Thank you very much for a patient listening.
Thank you so much, Dr.